Hello, everyone, and welcome to the HHQI Cardiovascular Learning Action Network, or what we call the CardioLAN webinar. We'd like to thank all of you for taking the time to join us today. We realize how busy your schedules are, and we hope that you'll find the content that we're going to discuss today very helpful and really on a clinician-based level so that we can help really improve the cardiovascular care of the patients in home health receiving. So just for reminders, this is the January 15th of 2015 webinar. We say that because this is being recorded so that we can have not only a reference for everyone to go back to as necessary when providing care and developing QI plans, but also for those whose schedules didn't permit them the time to join us today for the live event. So just to let you know who's on the call today, from the HHQI team, we have Stacy Dustick, who is the Health Data Analyst. We also have the 3 RN project coordinators. We have Crystal Welch, who will be along in a minute to talk about a few campaign updates. We also have Misty Kevich, who's an RN project coordinator, and she'll be along to co-present, and we'll talk about that in a minute. And myself, I'm Cindy Sun. With us today, we have a very special guest that we're very pleased to announce, Mary McGoldrick, and she'll be along in a few minutes to talk about the immunization, influenza, and the cardiovascular care, rolling it in together. She and Misty today are going to do a co-presentation. So I'm going to formally introduce you to Mary a little bit later in the call. So let's go ahead and get started and toss things over to Crystal Welch for campaign updates. Crystal?
Sure. Well, thank you very much, Cindy, and I'll just be brief. I'll let everyone know that our current participation in the HHQI campaign currently stands at 11,597 participants. We're very close to reaching another milestone, and those are from 5,045 agencies. So, of course, all these agencies have full access to all of the free education and data resources for HHQI. We are also very pleased to be honoring our January 2015 Agency of the Month, which is Golden Valley Memorial Health Care Home Services, and they are out of Clinton, Missouri. So congratulations to them. They were randomly selected among the home health agencies that are in the top percentile of performance in acute care hospitalization or oral medication management. So we're very pleased to be honoring them throughout this month of January, and they've been on our campaign website, and they were also featured in the HHQI Inside Edition e-newsletter that went out earlier this month. Those went out to about 15,000 contacts we have. So again, congratulations to Golden Valley Memorial Healthcare Home Services from Clinton, Missouri. Just another reminder that each month, HHQI, we're very excited to be providing even more of our key patient tools in Spanish. And we know that many of our home health agencies need those translated tools for their patients and for families. So as a reminder, each month, HHQI will post Spanish versions of some of our key patient tools, so just keep a lookout for that. All of the tools, again are free, and they are public domain. So feel free to use them as they come, or we get a question every once in a while, hey, can we customize these? Can we put our own logo on that? Absolutely. They're public domain, so customize them for your agency. That's not a problem at all. So if you're interested in seeing what Spanish resources that we have, just go to our homehealthquality.org website and click under News, and then you'll see the more Spanish resources that are available. So I just wanted to remind everyone of that really quick. We just also want to remind folks that there's a wealth of home health support right at your fingertips, and we had one of these opportunities last week. It was a little earlier in the month than we usually have them, but these are our HHQI live chats. So these are just live assistant opportunities that we have. So if you could just mark down Thursday, February 12th as the next opportunity. We just come together every month. The HHQI team here and campaign participants, we just come together online to share experiences, offer insights. You know, so if your agency is facing a quality improvement challenge, just check us out and check out live chat next month and post a question online there, because the chances are if you are having an issue, another agency in the HHQI community or home health community has had or is currently having a similar experience. And so we all might might be able to help each other and offer some advice and resources. So just, like I said, we call these live chats. So join us, and that's going to be next. The next is Thursday, February 12th at 2 p.m. Eastern Time. So if you want, you can always go to our website, homehealthquality.org, and under Network, and set yourself a reminder for the next live chat. Finally, just one quick announcement. This is an upcoming webinar. This is for our underserved population, or UP or UP, as we refer to it. And this is a quarterly networking event. We're very excited to be offering this. This is going to be January 28th. That's on a Wednesday. And it's from 3 p.m. to 4 p.m. Eastern. This is a wonderful educational webinar and an opportunity that we'll be able to discuss the roles of physical therapists, occupational therapists, speech therapists in the home health, and the expectation each discipline within their scope of practice to improve patient care outcomes. The topics that we'll touch on include taking vital signs, auscultation, medication management, the OASIS, and just involving therapists into your quality improvement activities on a daily basis. And the presenters, they're going to provide some insight on how to change those practice expectations, how to engage those therapists, and as well as just so many resources for home health leaders. And so the guests are Bud Langham, physical therapist and chief clinical officer out of Encompass Home Health, and Ken Miller, a physical therapist and clinical educator out of Catholic Home Care. So this is recommended for agency leaders, quality team, your nurses, the therapy managers, therapists, QINs, QIOs. This is just really going to be a great session with these great speakers. And actually, this is the first of a couple of more sessions that we're going to have. Cindy might be able to tell us a little bit more about that, but our next one will be for this Cardio Land meeting in April. So don't miss that opportunity either, because Bud and Ken, they're going to be just talking about the utilization of therapists and lay the groundwork for improving patient outcomes in cardiovascular health. And leadership really want to help therapists participate in things like med reconciliation, performing daily blood pressures on patients. And Ken and Bud are really going to talk about how getting therapists to work in their scope of practice and how to maximize using therapists to improve our outcomes and maximize their participation to the fullest within their state regulations. So I just encourage everyone on the call to register for this. And as of last week, we had well over 300 registrations. It had just gone out, so register, get a seat, and the session is going to be recorded. So it's always nice to have something like this available when the opportunity arises at your home health agency or wherever you may be with your QI and QIO, because you can always pull that session up and look at it at a later time. So registration is now open. Just go to homehealthquality.org under the UP or Underserved Population tab and register for that. So with that, I am going to turn it over to Stacy. Stacy?
Thank you so much, Crystal. And I'd like to thank everybody for joining us for today's webinar. It's great to have you here. So as a reminder, this portion of our webinar will include sort of an overview and a discussion of the happenings in the HHCDR, or the data registry. So we'll keep in mind for this month's call that the registry just closed yesterday. The most recent data that was abstracted and closed out has been pulled, and it's now being manipulated and put into production for those reports. Also remember that the new data for this month's abstraction is up there and ready for you to go ahead and begin abstracting. So while you're waiting for your data registry reports, you can start abstracting on your next month. We plan to have the reports available right around the 23rd of the month, along with all of our other HHQI reports like the ACH, oral meds, flu, and pneumonia vaccination reports. So, and just bear in mind that moving forward, as we progress with the data registry, we will begin discussing how to interpret the reports and how to use them to help improve the cardiovascular health of your patient population. So be sure to look for more in future CardioLand webinars. So like I said, bearing in mind that the registry just closed and I didn't have a whole lot of time to play with the data and really get some great numbers for you, I do have some interesting things to report. For example, the total number of patient episodes abstracted increased by 50% from last month to this month, so that's spectacular. It just really means that people are getting out there and they're abstracting, more and more agencies are being involved, and it's awesome. And I congratulate all of you for that because it's definitely a group effort on all of home health, from leadership all the way down. So great job. Now, the most recent, or the most abstracted measure continues to be the aspirin as appropriate measure. Again, it's followed by blood pressure control and smoking, and then cholesterol, again, brought up the rear. But I would like to definitely point out that people are abstracting the cholesterol measure at a much more frequent rate than they were last month. So that means that you all heard my challenge last month to abstract more, and you met that challenge. So very good. I'm so excited to see this, and we've just had tremendous participation, and it's wonderful. So if you have any questions at all, I or Cindy or anybody on the call will be happy to answer them during the Q&A section of today's webinar. So just, put those into our chat window or into our Q&A window, or go ahead and when the Q&A opens up at the end, you can just, ask over the phone, shoot us an email. We are here to help you and are happy to answer any questions that you might have. So before I leave you, I do want to issue another challenge since you rose to last month's challenge and abstracted more and more of the cholesterol. For this month, I noticed that there are some agencies who started abstracting maybe September data, but there is data available all the way back to July. So this month's challenge is, if you're missing any data, to go ahead and go backwards and abstract. That way you have a fuller picture. The more data you get in there, the bigger picture and the more clear picture you're going to go ahead and get of how you're performing on those measures. So we'll see next month if y'all can do it again and rise to this challenge. And with that, Cindy, I'm going to pass it right back to you.
Thanks, Stacy. And as Stacy said, she just got the data last night, so she's only had a few hours to look at it. And we're hearing the numbers for the first time, too. So I would like to reiterate what Stacy just said and say congratulations. A 50% number of episodes abstracted, that's huge, you guys. So nice job. We did hear from quite a few agencies who did accept the offer to just start with aspirin, not really sure what you're getting into, and that's understandable because that is probably one of the easiest measures to abstract, and totally understand. I'm not sure that I would want to jump in with both feet, but we have heard from many of you, and we appreciate your feedback as to how simplistic the registry is, and we actually heard from many of you wishing that you could open the registry to additional measures for that month, but we can't do that. Once you've selected your measure and you've stuck with aspirin for that particular month, that's all we can do. But moving forward in the following months, you'll be able to expand it as far as you'd like and to abstract other measures as well. So congratulations to everyone. Now, with that note, I will go ahead and begin our introduction of our presentation today, and I would like to introduce you all, if you have not been introduced to her before, Mary McGoldrick. She is an MSN, RN, CRNI, and she began her home care career more than 35 years ago as a home health aide, and since that time she has served in a myriad of home care clinical management and executive level positions, including serving as a hospice volunteer and 12 years as a home care and hospice surveyor for the Joint Commission. For the Joint Commission, Mary also served as an educational faculty for 10 years, providing education to the public at large on home care and hospice standards. During her employment with the Joint Commission, Mary was selected to be the nurse surveyor on a survey team with a physician and hospital administrator to conduct surveys of the Joint Commission against its own non-patient care standards. An author of more than 90 published articles and several books and chapters and manuals, Mary is a member of the editorial review boards for the Journal of Infusion Nursing and the Home Healthcare Nurse Journal. Mary is a department editor and contributor author let me start that one again. I do not want to miss any of this. Mary is a department editor and contributing author to the infection prevention column for the Home Healthcare Nurse Journal. Mary is also co-author of the first and second editions of Infection Control in Home Healthcare and Hospice book, the official publication of the Association for Professionals in Infection Control and Epidemiology, and the author of the Home Care Infection Prevention and Control Program Manual as evidence-based on home care and hospice infection prevention and control policies and procedures. For the Infusion Nurse Society, Mary is the author of the Infection Prevention Control chapters in the textbook Infusion Nursing, an Evidence-Based Approach, and the core curriculum for the Infusion Nursing, the 4th edition, and is also a member of the 2016 INS Standards and Practice Committee. Mary has served on the APIC-HICPAC and CDC committees to develop surveillance definitions for the home health and hospice industry and the Joint Commission's Expert Advisory Panel for updating the infection prevention and control standards. Mary currently serves as an infection preventionist and consultant for home health agencies and hospices and is the chairperson of the Board of Directors for the Infusion Nurse Certification Corporation, the INCC, through 2015. Mary is a frequent speaker on the topic of infection prevention in home care and hospice and was an invited speaker at the CDC's 5th Decennial International Conference on Home Healthcare Associated Infections, and speaker at the APIC's 2012, 2013, and 2014 annual conferences. I think at this point you will probably see why we were just thrilled to have her share her knowledge and her wisdom on today's CardioLand event. And with that, Mary, I would like to welcome you and turn it over to you.
Very, very much. I appreciate your inviting me here to speak with you today about sort of a very hot topic right now. And that is seasonal influenza. We are in full-blown influenza widespread outbreaks right now. So anyway, it was only a few months ago that Ebola was the hot infection control topic, and it still is an important topic. And as of this past Sunday, there were over 21,000 cases and over 8,400 deaths from Ebola. But really, the seasonal influenza is also a significant illness that affects up to as many as 50,000 people in the United States die per year from seasonal influenza. So it really is an important topic, and so what we want to do is focus on preventing the flu and also the complications associated with the flu. So let's, my slide is not advancing. There we go. Okay, so let me tell you a little bit about what I'm going to be talking with you about this afternoon. We're going to begin by reviewing the 2014 influenza season and talk about some of the challenges associated with that. We're also going to be talking about the influenza vaccination coverage of our healthcare workers and how we can improve that, and also to talk about how we can implement some of the best practices and things that you can do to hopefully prevent from getting the flu yourselves or also some of your patients. So let's first talk a little bit about this particular flu season, the 2014-2015 influenza season. This particular graph shows a display of the number of influenza cases that have been reported by the State Department of Health's epidemiologists. And if you look at your particular state here, if you find yourself here, you can see that most of the states are in a widespread influenza activity. 46 of the states and also Guam have reported widespread influenza activity. Actually, the only place that has local activity was the District of Columbia and also Hawaii. So I guess we might need to go to Hawaii to avoid influenza. I'm just kidding. But anyway, in December, the CDC, on December 3rd, the CDC issued a health advisory regarding a potential drifting of the virus that's currently circulating. What's happened is that the influenza A, the H3N2 virus, that's circulating right now. It's drifted, and I'm sure you've probably all heard that the virus, the vaccine that we've been immunized against, that it's not really a good match for this particular season, which is problematic. So one of the problems with this, the H3N2 predominant seasons, is they typically have been associated with more severe illness and mortality. So what we really want to do is try and prevent as many adverse outcomes as we can from this particular flu season. Now, if you look at this next slide, this to advance, it's not advancing, hang on. Well.
Yeah, just a second, Mary. Let me see if I can help.
I'm clicking away here, and it's not advancing.
Try using your mouse to click on the screen. Sometimes that helps.
Okay, I'm doing that too.
Hey, Cindy,
no.
Can you see, what slide are you seeing? Are you seeing the line graph chart?
I am.
I'm seeing.
Yeah, it looks like we're on slide 6.
Could you go ahead and take over the ball?
Thank you. Very good. Okay. So if you look at this particular next slide, this is looking at the immunization of healthcare workers, and we are so far from the National Healthy People target for 2020 of a 90% influenza vaccination rate. As of the 2013 influenza season, we had a 75% vaccination rate, and like I said, we still have quite a ways to go for that. So I don't know why my slide is not advancing again. Okay, thank you, whoever just advanced it. Thank you very much. I apologize. If you look at this next slide here that shows the coverage by occupation, look at who's the highest. It's the pharmacist. Well, it's quite easy for them because they can go through and, they have easy access to the influenza vaccination. But you know what? Look who's at the bottom. It's the aides with almost a 47% influenza vaccination rate. And so really what we want to do is try and increase that number and really focus our education activities with our home health aides to try and get that number higher, because you know what, we look at the aides, they are the ones that are spending the longest period of time with our patients and bathing them, and also in closest proximity to our patients for the longest period of time. So we definitely want to reinforce to the aides the importance of getting the influenza vaccine. Now, if you look at this particular slide that shows where individuals are working that have the highest influenza vaccination rates, I don't think it's any surprise. You can see the hospitals are the highest. And typically the hospitals have mandatory influenza vaccination programs, so they typically have higher rates along with that. There's also a number of different states that have been very progressive in mandating the influenza vaccination for all healthcare workers during flu season. And some of those are New York, Colorado, and also California. So some of you may be in some of those states that when the State Department of Health has sort of declared that we're in widespread activity, which we are now, any non-immunized staff would need to wear a face mask in the presence of any patients. So it's not advancing again. I'm so sorry.
Mary, it's no problem at
yes.
all. Let us know when you want to advance it, and Misty will take care of that for you. We just are appreciative of you being on the line today, so you just tell us when you want the slide moved.
No, I know that, but anyway, thank you very much. Okay, so if you look at this next particular slide and look at the organizations that have mandated, employer-mandated influenza vaccination programs, look at their very high influenza vaccination rates, and that's certainly of no surprise. When, if you look at your infection prevention, your immunization and infection prevention BPIP, your best practice intervention package, there are a couple of very interesting organizations that are highlighted in that. For example, you may want to go back to page 47 of your BPIP after the program and look at the story that was written by Lisa Lowry. Lisa is from the Franciscan VNS in Indianapolis, Indiana, and they started a mandatory influenza program in 2011. Now, the staff can still decline the vaccine based on any religious or medical contraindications, but one of the things that I think that they've done that's a little bit unique is they require, if anyone wants to claim those exemptions, they have to have documentation that they have to submit, and then this documentation goes to a committee, and the committee will make a decision whether or not to accept their documentation or not. So, gee, and there's no surprise, their influenza vaccination rate went up to 90% from 62%. And then another organization that's highlighted in the BPIP is on page 55, and that is Julie Newman from the Visiting Nurse Health System in Atlanta, who actually this organization started their mandatory influenza program back in 2006, really sort of before it was cutting edge. And you can read about Julie's story too, and some of the challenges that she has, and sort of words of advice on being strong and being patient and sort of hanging in there, that you too can do that. So if you don't mind advancing to the next slide, please. If you look at this particular next slide, looking at the place of employment, you can see that most of the healthcare workers who have been vaccinated get their vaccination at their place of employment. So that's easy for the hospitals, but it's not always so easy for home care organizations. And I do know that one of the success stories that was highlighted in the BPIP with Visiting Nurse Health System of Atlanta. I happen to know that Julie set up flu clinics all around the Atlanta area and actually went out to where the staff were located out in the entire metropolitan area of Atlanta to try and really focus on getting the staff immunized. And so that really worked for them, and that's something that you certainly may want to consider. This next slide is looking at the number of, the reasons as to why the staff wanted to accept the influenza vaccination. You can see most of the staff are, trying to protect themselves. But one of the things that's important, though, is that influenza vaccination really is a patient safety strategy. It's a way for you to hopefully prevent our, elderly homebound patients who are not going out of the home and may not have been exposed to the influenza virus, to prevent those individuals from getting the influenza illness, if you will, and some of the secondary complications. This next slide is looking at the reasons as to why people decline, and I have a feeling this particular flu season, with the vaccine not being a good match with the circulating virus, they're sort of going to fuel the fire for people that say that, they don't think that the vaccine works. We're going to get a lot of sort of I told you so's for this particular flu season, but it is really important to know why your staff are declining the influenza vaccine so that you can target your influenza education for the subsequent flu season. Now, each CMS reporting home health agency also has access to this information as to the number of patients in your agency that accepted and also declined the influenza vaccination. that's in your HHQI data report. So that's something that you may also want to pull up and look at, and Misty will be talking a little bit more about that. So when we look at the best practices really within an organization and how we can prevent the flu, it's really tiered from both perspectives. It's really from an employer standpoint and then sort of, you know, out in the field perspective. So let's talk a little bit about the employer best practices and things that you can do. Now, the first thing that's most important is for you to have a formalized influenza vaccination program. For those of you that are accredited by the Joint Commission, it was back, I think it was 2012, that the Joint Commission established standards for requiring accredited home care organizations to have a formalized influenza vaccination program under standard IC241. So again, it's to have a more formalized, systematic program, but as part of that, you want it to be able to know on an annual basis who accepted the influenza vaccination and who declined it. So that would be an important piece of data that you would want to collect on an ongoing basis, again, to not only know who declined, but why they declined, so that you can aggregate and analyze that data and focus your staff education on an ongoing basis for that. Also, too, with tracking the influenza vaccination status, on page 21 of your BPIP, there's some great suggestions in there for how you can actually track your influenza vaccination status for your employees through different spreadsheets or collecting HR data, but that would be an important component. Staff education, again, for organizations that are accredited by the Joint Commission, there is an element of performance that specifically mandates the content of what has to be included in the staff education. Everything from about the influenza vaccine, some non-vaccine control and prevention measures, and also the diagnosis, transmission, and impact of influenza. So again, the education, you want to make sure that at the beginning of every flu season that this is something that you are educating and really promoting vaccination with your staff. Now on page 56 and 57 of your BPIP, there are some leadership talking points that you may want a specific reviewing and going through with your education. It's broken down by clinicians, aides, and also office staff, and it gives you sort of some, I didn't write these, but they're very good, some sort of canned language and, you know, things that you might want to focus on. You know, for example, when you're talking with the clinicians, you know, it's as if your grandmother was on home health services. Would you want her to be cared for by staff that were not immunized by, you know, for influenza? Well, probably not. So there's lots of different examples of how you might want to frame your education and how you may want to emphasize that. Also, too, on page 59 of your BPIP, there's also some excellent formulas for you to develop some models and for you to collect some data as to, you know, really what's going on within your organization from an influenza standpoint, to look at, you know, for this particular flu season, how many days were staff out sick, looking at the reasons that staff were out there, because you know what, if staff are not, you know, immunized, I mean, you guys know what problems it can cause when there's no staff to go out and make, you know, the visits, and having to juggle schedules and contact staff, and, you know, it can affect satisfaction rates. I mean, the whole process, it really just snowballs. So that's an important factor. But this particular page, again, it's page 59, has some excellent formulas that you can use to evaluate your influenza vaccination program at the end of flu season, which would be March 31st of this year. One of the things that you should be doing is aggregating your influenza vaccination rates, again, the acceptance and declination, and looking at some of this data, looking at the number of days that people were out sick and the overall effectiveness of your your influenza vaccination program. Now, from a patient care perspective, we definitely want to, we're going to definitely, push our staff to get the influenza vaccination, but we also want to reinforce to the patient the need to get their flu shot. Now, usually by January this time, 90% of the people that are going to accept the influenza vaccination have already gotten it, but it's not too late. So you still want to encourage that, but another very important component for your staff or even for your patients is to consider and really focus on the use of antiviral agents, because that's a very strong component, because we know it's not a good match this year. So what we want to do is teach our patients that at the first sign that they might have the flu, or even your staff too, that they need to, contact you, contact the physician to consider getting tested, or even having the physician empirically prescribe some of these antiviral medications, that they can be a very important adjunct to, individuals who do develop the flu, especially if the antiviral agents are initiated within the first 48 hours of developing influenza. They can help reduce, they can shorten the amount of time or lessen the severity of the illness, and maybe prevent some, hospitalizations, subsequent pneumonias, whatever. So I really want you to consider and really think about these antiviral agents, and actually a new, Tamiflu and Relenza, those have been the two that have been out there. But actually, this past December, there's another new drug out on the market, Peramivir, that also can be used in treating adults. So that's also a very important component. Now, hand hygiene, everybody's heard about hand hygiene, and, we all know that's the most important thing to prevent infections. But you know what? When you're in patients' homes or just even out and about, the influenza virus can lay dormant on surfaces for, up to 24 hours. So you may have just washed your hands, and then you have environmental contact with something else. It could have been a surface where the influenza virus was there. One of the things you want to focus on is making sure that you are not touching your eyes, your nose, your mouth. You're washing your hands before you're eating, so that you are not self-inoculating yourself with the influenza virus and, contributing to yourself getting sick. So again, we all know about hand hygiene, but just to be very aware of that. Following standard precautions, following cough etiquette, respiratory hygiene, covering your cough, coughing into your sleeve, washing your hands after you touch your nose, and then certainly with droplet precautions if you are caring for a patient that is sick with the influenza virus, if you are going to be within 6 feet of that patient, to make sure that you are wearing a face mask. So, sort of in summary, this particular flu season, it's not a good match, unfortunately. We still need to promote the getting the vaccination for our staff and our patients, but don't forget about the use of antiviral agents. I think that's also another important component. That really our focus for this particular flu season needs to be on preventing any severe disease and outcomes associated with that. So, we talked about, some of the best practices and things that you can do within your organization. And also, too, you may want to look at page 23 of your BPIP. There's also a nice checklist for your immunization program and things that you may want to go through to go ahead and strengthen your program. So I thank you very much for your time, and I am going to go ahead and turn the program over to Misty, who will go ahead and take over from here.
Thank you so very much, Mary. A lot of great information for us to think about, and not only from a home health perspective, but really any setting, and also not just from a general perspective, but also cardiovascular. And that's kind of where I'm going to start to capture today to tie in to the cardiovascular health, being that that's what, our focus of our calls have been talking about ways that we can improve cardiovascular care, and immunization is a way. There are a lot of studies that are out there. Now, the next several slides that I'm going to go over, there's a lot of information and there's a lot of detail here for you to be able to use as a reference or to go and read the articles that I'm going to just mention. Immunizations and cardiovascular health, the CDC shows that there is a correlation. They recommend for people that have heart disease, strokes, or cardiovascular disease to get all of the immunizations that are on the screen. But the two we're going to talk about is influenza, which Mary's just told us a lot of information about related to influenza, and I'll touch on the pneumococcal vaccine as well. The CDC states that people with heart disease and those that have had a heart attack or stroke are really at a high risk for developing serious complications. That results in hospitalizations and even deaths. So they have found, looking at the data for those patients that were in the 2013 and 2014 influenza disease, that 37% of the adults that were hospitalized with the flu had some type of a heart disease. Well, it's definitely not surprising from home care. We see a lot of our admissions have some type of a reference to a heart disease readmission or an admission rate. But the studies have shown, and they continue to show, an association of having influenza and having a higher risk of heart attacks and strokes. And when they talk about heart disease, when CDC talks about heart disease, it's just not coronary artery disease and coronary anginal or heart attacks or strokes, but they're even looking at heart failure, hypertensive disease, and some of the other diagnoses that are on this slide. So getting the influenza can create complications for our cardiovascular patients. Then the research showed the other direction where, well, I'm sorry, before I get to that slide, I did slip this one slide in here. There are the different types of influenza vaccinations, and the nasal spray, which is the live attenuated influenza vaccine, normally that is given to people that are under 50 years of age, and then there may be some other qualifications for why they should not, that they could not receive it. And cardiovascular, except for hypertension, is one of the reasons that even if you're under 50 years of age, you should not receive the nasal vaccine. You should receive the IM or the intradermal vaccine. We see a lot of patients that are under 50, especially our Medicaid population. So it is important to know that. I'm not sure how many home health agencies do provide nasal vaccines in the home. I know most of the ones that I'm familiar with are still providing the injections. But just so that you know that if you have a cardiovascular disease, you should be receiving the IM or the intradermal. And let's see, now let's look at some research results. The influenza vaccine has been shown in numerous studies, and it continues to show that there is definitely an association. Not necessarily do they understand how it is doing that. There is some indication, a little bit more. In the second study, I'll give you a little bit more indication here. The first study is showing that receiving the vaccine lowers a person's odds of getting a heart attack, stroke, heart failure, or other major cardiac events, including death, by about a third. And it's over a year, so that you get that benefit of the flu vaccine for over a year and giving you that heart protection. And one of the interesting points in this study is those that are at the highest risk of cardiovascular risk actually are getting the greatest benefit from the immunization. So, this is a really good talking point, too, as we continue to talk about our frail and elderly patients and those with a lot of cardiovascular health. They really are going to get a bigger benefit from the vaccine, as well as not getting the disease, which could also provide them complications. And in the second study on this slide, they're finding that they believe the vaccine is stimulating the immune system to produce antibodies that kind of switch our cells on, and it really does give that protection to the molecules that protect our heart. And I thought that was that was very interesting. And I am going to pull on the next slide a comment from the author of that second study, but you can read that in every single study related to immunizations. is, unfortunately, the rate of administering flu vaccines is disappointingly low, even in developed countries. We hope that our results will encourage more people to get vaccinated before the flu season starts. I know Mary really has talked early on about this as being very epidemic, one of our worst flu seasons. So next year, we may see a little bit of a bump up in people getting immunized. Sometimes I worry more about having a mild flu season the year before because we kind of see our rates dip down. And I'll come back and touch about the HHQI immunization reports here in just a minute and why they're so vital in your planning and your activities. Now, with the pneumococcal immunization, there are it is recommended, normally the recommendations is for those people that are 65 and older should receive the pneumococcal immunization, but then there are recommendations for those people that are under 64. And again, we see a lot of those people under 64. And some of the issues of why they should receive it include the following cardiovascular risk factors. If they are a cigarette smoker or any type of chronic cardiovascular disease, such as congestive heart failure or cardiomyopathy. Now, there are other conditions that are recommended, but these are the cardiovascular reasons that patients should receive the pneumococcal vaccine, even if they're under the age of 64. Okay, and our next slide, make sure I get to the right slide here. This study shows that a person who is at risk for heart attack and gets the pneumonia vaccine can actually cut their rate in half. That's 50%. To me, that's very significant. The study went on to tell you they focused on people with risk factors for heart disease, not just with heart disease diagnoses, but those with high blood pressure or diabetes because they're at high risk. The findings found that they not only got the protection, but it was for a 2-year heart protection time frame. They're again not clear how this is occurring, but study after study is really validating the same type of findings, just they have to do more research to figure out why it's happening and how it's happening. Now, Mary was gracious enough to reference back to HHQI's best practice intervention package, immunizations and infection prevention that is out on the website. You can download it. She gave you some great page numbers that you could look at. The bulk of the package is related to immunizations, and it focuses primarily on influenza and pneumococcal. There is some other tools that are in there that do include some of the other vaccines that are recommended for adults. Gives ideas, a lot of tips and tricks and tools, so do check that out. It's worth you taking a look at that. The other piece that Mary talked about is the data, the HHQI data. Every home care agency that collects CMS data and a Medicare certified agency that's submitting OASIS data, we do have free immunization reports that are available every single day, or every single month, I guess, but they are there every day. They just need to go out to their data reports and pull them down just where they get their acute care hospitalizations and where you go in and the data, you go in to the database to get into the Cardiovascular Data Registry, but in that earlier screen, you're able to go get your other reports. And it takes a look at influenza and pneumococcal, and it takes a look at those by what's your rate of receiving. Doesn't matter if you're administering it or if they receive it from another location. It also takes a look at why they're not receiving it, because you might think you know why patients are not receiving their immunizations, or you go by what you hear from staff, but you really need to see the bigger picture, and you need to see the data and the facts as to why. And then you tailor your interventions and your strategies around the reasons why they're not getting it. You know, a lot of times it is education. And then even though we're not reporting agency employees' data, although hospitals are now starting to do that, you really do need to have a way, and we give you some insight in how to do that in the best practice package of your employees. And you need to figure out why they're not. A slide that Mary showed earlier talked about the reasons why people of healthcare workers not getting it, the vaccines, as well as who's not getting it. And home health or aides were at the very bottom. So that's an easy place to start. Even a lot of times it is the myth. I mean, it is the myth that I'm going to get sick if I get the vaccine, and it is taking that and breaking that apart. So anyway, you really do need to look at your data. It does take the data down by race. It looks at payment sources as well as age, and it really does provide you a lot of insight in helping not only to plan. So we may be coming down from our flu season. You know, hopefully we have crested over. The news still this morning said we're not real sure. But as you start to gear up, this is the best time of the year to think about what worked, what didn't work. Let's take a look at our numbers. Why did we have a lower rate of immunization? And start to dialogue and ask your employees, find out what's going on and really get the good data. And then you'll be ready for your planning through late spring and into summer so that you'll be able to kick off early. Because it seems our vaccines are usually available now by August, and it seems the flu season has started a little bit earlier, so you need to be prepared as well. So with that, I'm going to go ahead and give it back to Cindy, and we can do questions and answers.
Thanks, Misty and Mary. That was really a great presentation, great content, not only timely for influenza, but also how it relates to cardiovascular care and that we're all providing and want to provide the safe and most evidence-based care. So thanks for bringing that up for all of us to hear again today. So let's go ahead and unmute the lines and just ask what kinds of questions you guys have out there. And remember, it doesn't have to just pertain to today's subject matter. It can be about anything cardiovascular, the HHCDR, or any questions that we can help you with while we're on the line today. And Misty D, do I assume that all the lines are unmuted?
Yeah.
Wonderful, thank you. This is a quiet bunch today. All right, well, we'll just go ahead and just take a minute here to mention that, remember, your influenza pneumococcal reports are available to every single CMS reporting home health agency. It does not matter if you are participating in the HHCDR or not. Those are there waiting on you. It doesn't matter if you requested them or not. Those reports for all 12,000 agencies are just sitting there waiting, and there is a lot of information for both of those. Like Misty and Mary both said, finding out why your patients are refusing is a very important aspect when looking at providing safe and effective care. Is the majority of the rationale because they don't want to accept a shot? You know, is it the way it's presented, or is it the way they're educated, or is it something else completely out of your control? So that's something you will want to review if you have not done so already, so that you can make a change and a difference to your patient's health and safety. So we'll stop one more time and just see if there's any questions. I see a few hands raised on the screen, but if you want to go ahead and unmute your line and speak, that would be wonderful. Well, while we're taking a minute here, I'll ask Mary if she had any additional points that she wanted to elaborate on, because I know we had your time as a very short time here with us today.
You know, really, as we talked about, just really focusing on vaccination. It's not too late, but also focusing on the early detection and early empiric antiviral treatment, especially for any of our patients that are suspected or confirmed of having influenza, and especially our patients, you know, that are high risk for complications, because by getting our patients on antiviral therapy, you know, if it's appropriate for them, of course, if their doctor orders it, whatever, we can help reduce, you know, the patient's risk for hospitalization, reduce risk for pneumonia, and that's what we want. We want to keep our patients, you know, safe at home and healthy and out of the hospital, and you know, it's just, you know, it sort of gets back to some of the basic infection control measures, and even for the staff that may also, you know, I hope they don't, but if they do get sick with the flu too, sometimes after, that they need to be very aware of going out and making home visits when they might be sick. And sometimes even after you're sick, sometimes you might have a little, subsequent cough, and for the staff to be just very aware of, putting a mask on if they need to, and washing their hands, and really focusing on respiratory hygiene and cough etiquette, and just sort of getting back to the basics of infection control. So that would be great.
I think, again, those are just incredibly, it's wonderful that you brought it back, because those are great points to be made, and it's something that we all, in healthcare and especially in home health, we have heard it so many times over and over about this, but this is something that, as we're seeing on every news channel, that the epidemic proportions are going around. And if you think about how we move from house to house in infection control, and especially our high-risk patients, which are our cardiovascular patients, it's something of vital importance. Keeping our patients out of the hospital and safe and healthy in their home is most important. And the last thing that any of us in the home want to do is to be the causative agent for a problem that our patients will occur. I mean, that's not the reason that we go into home health. So I think thank you very much for bringing those points back up. So we'll pause one last time for any questions before we close out the meeting. All right, hearing none, I just want to remind you that we did see on our polling that most have received their influenza vaccine. If you have not, as Mary and Misty have said, it is not too late to receive it yourself if you are interested in doing so. The recording of this webinar, as well as the slides, handouts, are located on the HHQI website, which is www.homehealthquality.org. It's under the CardioLan link. And I'll just make a reminder that January 28th, if you have not already registered, this is something vitally important. So we have heard from your feedback as such. The underserved population webinar is something that those of you in this group have asked for many times as well. So we're very excited to have the scope of practice of physical therapists, and really all therapists in the home, presented by the APTA. So we do hope that you will join us for that webinar. The next CardioLan will be on February 19th, 2 o'clock Eastern. This group will meet back together again. And at that time, Karen Hudman from the RX for Change will be presenting on smoking cessation, the cardiovascular care, and really how smoking and tobacco use not only pertains to cardiovascular, but all systems. So if you're working in an agency who has a wound specialist, or you have nurses or clinicians who are interested in wound care, they may find this topic extremely interesting, and it's not just cardiovascular. So we hope that you will all register and join us for that. I want to continue to encourage you to abstract your data and enter it into the HHCDR. As Stacy and Stacy's Corner did mention, the registry is now open with newly populated data. Please go back and abstract as much as you can and enter it. That will give you a larger, bigger, truer picture of what's going on in your agency. And a final reminder is for many of you in your individual states, your QIO, Quality Improvement Organization, is holding a post-conference, or you may have your post-conference scheduled for tomorrow. I'd like to remind you, if you are not participating with your QIO, those are your quality improvement experts located in your individual states. Remember, they are free and wanting to work with you, so please reach out to them. If you're unable to figure out who it is to contact us. We're at hhqi@wvmi.org. And we'll help you locate the email address and then get you in touch with the right people. So for those of you that are in contact with them, remember that you probably have office hours and meetings after this, and you may have one scheduled for tomorrow as a kind of a debriefing at your state level. So we want to encourage you to participate in those as well. So with that, we will say thank you, all of you, for joining us. And until we talk again next month, have a great day and happy Heart Month. Bye, everyone.